And thank you all for coming. Some of what I'll be talking about today is part of another recent report that PPIC put out on the local-state relationship and how that might change in the context of ACA implementation. And I believe there are a few copies of that report in the back of the room if you're interested. So federal health care reform legislation, the Affordable Care Act, I'll refer to it as the ACA throughout this presentation, includes several provisions to expand health insurance coverage, most of which are slated to take effect in 2014. Chief among them is the expansion of state Medicaid programs. California's Medicaid program, Medi Cal, currently serves nearly 8 million low-income Californians. To be eligible for the Medi Cal program under current rules requires both a low-income. Current eligibility levels are set at about 100% of the federal poverty level for most adults, and also the presence of a dependent child or a qualifying disability. In January 2014, the eligibility criteria expands to a slightly higher income level, 138% of the federal poverty level, which is about $16,000 a year for a single person, and also opens the program to non-disabled adults with no children. All citizens and legally residing immigrants who have been in the U.S. at least 5 years are eligible for Medi-Cal under the federal rules, although the state could choose to cover legal immigrants in the U.S. less than 5 years under Medi-Cal using state-only funds as it does now. The ACA also simplifies how income eligibility is determined and calls for integrated, streamlined systems to verify information and process enrollment as easily as possible. The federal government is slated to finance the vast majority of the costs associated with the coverage expansions prescribed by the ACA. For the first 3 years of implementation, from 2014 through 2016, the federal government will bear 100% of the cost of expanding Medi-Cal coverage to those made newly eligible for the program. And after that, the federal contribution will gradually decrease, dropping to 90% by 2020. Oh, finally, the Supreme Court ruling last year upholding the law did make the Medicaid expansions optional for states. But California has chosen to move forward with the expansion, as evidenced by both the governor's budget proposal and the recent passage of expansion bills in both the Senate and Assembly. The governor's proposal outlines two options for the expansion. A state-based approach would build upon the current state-run Medi-Cal program. The county-based approach would build upon existing county-based health programs, including county low-income health programs, often referred to as LIPs, which were created and funded as part of California's Medicaid waiver in 2010. The LIPs provide health care services to many of those expected to become eligible for Medi-Cal when it is expanded in 2014. All but a handful of counties have implemented LIP programs, and current enrollment is nearly 500,000 people. The waiver also provides federal funding to support public hospital and clinic systems and includes investments in delivery system reforms and infrastructure. It's difficult to predict exactly how the coverage expansions will play out in California. Fortunately, there are researchers at UC Berkeley and UCLA who have developed a model that takes into account the expected response of individuals and firms and uses that information to project the likely impacts of the ACA in California. According to that research, more than 1.4 million Californians are expected to become newly eligible for the Medi-Cal program. Of those newly eligible, between 480,000 and 780,000 are predicted to enroll sometime in 2014. By 2019, those enrollments are projected to increase to somewhere between 750,000 and nearly 1 million new enrollees in the Medi-Cal program. Now, this range in estimates results from different assumptions about the take-up rates for the program, with the lower bound estimate assuming a take-up rate similar to what it is today, and the larger estimate assuming a higher take-up rates due to increased outreach and simplified enrollment. This enhanced outreach and enrollment is also expected to bring people into the Medi-Cal program who would be eligible under the current rules but are not currently enrolled. And the federal government will only pay their standard 50% match to serve those currently eligible but not enrolled. Today, more than 7 million Californians are uninsured. The Medi-Cal expansion, along with the subsidized coverage available through California's new health benefit exchange, Covered California, is expected to cut that number in half. But 3 to 4 million Californians are projected to remain uninsured, and they are located throughout all regions of the state. The figure here shows the estimated number of uninsured individuals in 2019 by counties and regions under two different scenarios. The orange bars show the low estimate for remaining uninsured, and this is the one that assumes the increased take-up rates due to enhanced outreach and enrollment. And the gray portion of the bar indicates the additional number of people projected to remain uninsured if we assume the same take-up rates for the program as they are today. As you can see, the Southern California region will be home to the majority of those remaining uninsured, with more than 1 million expected to be in Los Angeles County alone. Among those that remain uninsured, some are ineligible for the coverage expansions due to immigration status, but many others should be eligible for either Medi Cal or subsidized coverage through Covered California, but are not enrolled. Under California's current safety net system, counties run county indigent care programs that provide health care services to many low-income uninsured adults who are not eligible currently for public coverage options, although these programs and who they serve vary considerably across counties. As many of those currently served by county programs gain access to Medi Cal, this shift to federally supported coverage should result in county savings, raising questions about the current financing of county indigent care programs. Changes to state funding to support county indigent care would have impacts across all counties, but particularly those counties that operate public hospital systems. 12 large counties in the state that are home to nearly 2/3 of California's current uninsured population operate these county-based hospital systems. Moving forward under the ACA, these public hospital systems may face additional challenges. Certain federal funding streams are set to decline, and there's also some uncertainty about whether patients with more choices for care will continue to use these public systems. So despite the progress California has made towards implementing key provisions of the ACA, there are still many unknowns. While we do have enrollment estimates available, there are still many questions around how many people will actually enroll in the program and what their particular health needs may be. The level of benefits offered to the newly eligible population is a decision with some state discretion. Federal rules allow states some flexibility in setting the benefit package. The costs associated with care for the newly eligible will depend on the benefit package, but also the health care needs among those who do choose to enroll. And there is some concern that a small group of those made newly eligible could have considerable need, including behavioral health services. There are also big concerns surrounding the adequacy of the healthcare workforce, in particular the geographic distribution of providers across the state, and also the willingness of providers to participate in the Medi Cal program due to relatively low reimbursement rates. And finally, given the large number of Californians expected to be uninsured even several years after the coverage expansions are in place, who will be responsible for providing care for this group and how will it be financed? And with that, I'll turn it back to Dave and invite our panelists to come up. Thank you.
Thank you very much, Shannon. So we are very fortunate to have a panel of experts who have been involved in this topic for quite a while and who are very much involved in some of the things happening this year, and who represent a variety of different perspectives that are very key to the debates coming up. For introductions, on the right side or your left side is Kelly Brooks-Lindsey. She's a senior legislative representative at CSAC, the California State Association of Counties. In the middle is Anthony Wright. He's the executive director of Health Access California, which is a consumer advocacy organization. And next to me is Mary Cantwell, who is the chief deputy director for healthcare programs at the California Department of Healthcare Services. So we will get started with a kind of an opening question or an opening statement kind of question. I'll start with you, Mary, but what do you think looking ahead this year is the most important decision, or what are the most important decisions that the state has to make to prepare for 2014?
There's probably a lot of decisions, but I think the biggest one that I think all of us are really interested in is the decision to actually do the expansion for the optional expansion. Obviously, we know that the governor has come out and said that's what we want to do. I think that's the first question, and hopefully the answer to that question is yes, we are going to do the expansion. And then it's really how we're going to operationalize that. Obviously, as Shannon noted, the governor has proposed two options in how the state might make the expansion, and obviously I know the members of the panel have particular opinions on that, and we are open. We want to have the conversation about how should it be structured, and the important thing from our perspective is how do we have a Medi Cal program, both the existing program and an expanded program, that's going to be sustainable for the state going forward. And so the key question for us then ties into the expansion is what's the role and the shift of responsibilities between the state and the counties that we are having ongoing conversations with our county partners about how do we look at that, recognizing, again, many of the things that Shannon noted, the moving pieces that we have and that there will be remaining uninsured. We don't disregard that and the important role that counties will play in that, particularly, again, the counties with public hospitals and their role in our safety net and making sure that they're viable moving forward. So I think the key question really is, are we expanding? Again, from our perspective, the answer is yes, and then it's how do we structure it and do it in such a way that is going to have a complete Medi Cal program that's sustainable, because there will be cost pressures, as you've heard us talk about before, both with the mandatory expansion that we term it, the simplification, the new people coming on that are currently eligible but not enrolled, and as well as when you have a larger program, and I think it's in some of the open questions that Shannon identified, there's other cost pressures about what are the reimbursement rates and how are we going to deal with access for 1 million, 2 million more people in a program that sometimes today has challenges.
Mm-hmm. And just I'm going to try and keep this as an educational kind of event for people who are not the insiders, but probably not the general public. It's those of us in Sacramento who really want to know a lot about this complex topic that's so important. Just try and, one of my questions is just to where the expansion question is right now. We have a special session, right? And could you tell us where the question about the expansion is?
Sure. I think when the governor called his special session, there were a few items that he said are sort of vital to talk through, and the questions related to the mandatory expansion and the exchange. All of those are things that, I know the legislature and all of us are working hard to try to do as quickly as possible. The optional expansion piece is complicated, and I think this funding question is vital to us as we try to make sure that we're going to have a sustainable program. And so how quickly we can answer that question and figure out the structure is a part of the conversation we're currently having with our county partners and with other partners. And so I think how the timing of that, we certainly recognize we need to make decisions as quickly as possible. There's a lot of work to be done. The department is ongoing work on the transition of folks in 2014, sort of regardless of the option, the things that would be the same. We're continuing to do that work with the expectation that we will have an expansion in 2014. How we will do it is the open question.
Mm-hmm. So, Anthony, looking this year, what are the biggest decisions do you think that are going to shape what this looks like in 2014?
Yeah, so again, Anthony Wright, Executive Director of Health Access California, the statewide consumer advocacy coalition, and we're really pleased that after, in our 25-year history of working for health reform, we're no longer on panels talking about the prospects of health reform, but actually talking about actually getting it done, and as was stated, with the governor's commitment to do the Medicaid expansion, I'm glad that we're also no longer talking about whether to do the Medicaid expansion, or at least I hope we're not, but that we're actually talking about how to do it the best way. So it's not just do it, but do it right and do it right now. And I think that's the big thing that I would sort of emphasize, which is, so what is the frame by which we make these decisions? There are options that states have with regard to how to, for example, make the changes and the reforms to Medi Cal eligibility and enrollment to make it a streamlined and simplified program so that people can. Is it easier for Californians to get on Medi Cal and stay on Medi Cal, which is, I think, a important public policy goal. Those are decisions that are reflected in the current special sessions bill, ABX11 and SBX11. And I think the frame for us is how do we maximize the benefit for California families and the California healthcare system? How do we draw down as much federal dollars as possible? How do we make sure that we provide the best possible care and coverage and benefit to California families in a healthcare system that desperately needs all the help it can get? And so that means taking advantage of those opportunities. I mean, we have a remarkable opportunity. The newly eligible, as was stated, is 100% paid for the first 3 years, and even in 2020 and beyond is 90% paid for. There isn't a better deal in government or in life than a 9-to-1 match. And so the question is, how do we really take that opportunity and really run with it? But I also do want to express the urgency, which is not just do it right, but do it right now. We don't have a lot of time. We are less than 7 months away from the beginning of open enrollment in October of 2013 for the new coverage options benefits. We are 283 days away from January 1, 2014, when these new coverage options become available. And if we are not ready on January 1, we lose that money. It's not money that we can recoup later on. The 3 years of 100% match starts on January 1, 2014, and ends on December 31st, 2017. We don't get to, it doesn't start, the 3 years doesn't start the day we start. It starts on January 1. And so we have, it's not just important, it's imperative that we do this with the urgency that is required. And I think the third thing is the third big decision is, how do we make sure that we maintain our commitment to the remaining uninsured, even if we do the best job of enrolling as many people as possible? And there's decisions we can make to increase enrollment and reduce the remaining uninsured. But even if we do the best job, we'll have 3 to 4 million remaining uninsured. And so how do we make sure that we have a safety net that survives and thrives? And I think that's going to be one of the key things that we have to lay out this year as we have that conversation about state and counties and the other issues of going forward.
Good, thank you. And Kelly, how about you? What are the big decisions you think this year that will, in the next 283 days?
I'm always happy to be with Anthony. He has like a little ticker in his head about exactly how long. So I actually agree with what the other two panelists have said, and I would expand a little bit. I think some of the decision-making around how the mandatory expansion is going to look and what some of those eligibility simplifications look like and who becomes eligible is going to intersect with who remains uninsured and the optional expansion. And so I think some of the decisions that are going to be made in the near term within the special session around the mandatory expansion are going to be very important, particularly as we worry about things like how quickly do people actually enroll in the new coverage options that are available. Our folks are particularly concerned about sort of who remains uninsured and sort of what does that set of responsibilities look like, and frankly, are the people who remain uninsured sort of even sicker than the general population, and sort of what does that mean for options for care? So I think it's certainly an intersection of multiple things, and I think something that hasn't been touched upon in too much depth is, what do the benefits look like for the folks that are going to newly get insurance? One of the areas where our folks are doing a lot of thinking is mental health and substance use disorder treatment, partially because we counties fund and operate those systems today within the Medi Cal context. But we know a lot of the other populations that we come into contact with who don't qualify for insurance now, like people who are in and out of our jails and in and out of the state prison system, are going to potentially be eligible for Medi Cal. And so we know that there's a need, particularly around those benefits. The federal government has benchmarks in place that, particularly on the substance use disorder side, are probably more generous than what we're offering today in the Medi Cal program. And so how do those change, and what do those look like? And is it an opportunity to actually bend the cost curve and do sort of a better job in addressing those issues so that we don't have bigger costs in other parts of the healthcare system?
Thank you. So the first question is one that nobody mentioned, but the governor, as Shannon alluded to, suggested that this newly expanded Medicaid population could be managed either at the county level or the state level. So, Mary, if I could start with you again, why did the governor not pick one? What is the reason for Or, what are the trade-offs?
I'm not sure I want to act as though I can speak as to why the governor made a decision that he made. I think we recognize, right, that today the role and the responsibilities that we have as a state and the role and the responsibilities that the counties have are intertwined in the delivery of health care. And so when we viewed on this optional expansion that there is going to be a change, we want to have expansion, we viewed it as a conversation and a partnership with our counties about what is the best way to do it, recognizing that there are a lot of complicated, intertwining financing and care delivery structures that to presume that we know the exact best way to do it without having that conversation with our counties was the reason that we put them both out. We believe that both are viable options. Obviously, I think we've heard from a lot of the counties that they believe that the state option is the way to move. Obviously, a couple of counties have actually said the opposite, and they would like to do the county option. And we are fully open to either option and really exploring the details of which option would work best for us as a state, for the counties, and for the care delivery system. And so we're working now, as I mentioned, with our county partners on exploring each of these options more in detail to try to understand how would it work and how would then the shifting responsibilities and costs play out, recognizing, again, the point that Anthony made, we have to have a vital safety net, and the governor is very committed to that. And how does that look, and how does the changing relationship impact that as well? And it is, for folks who've looked at Medicaid financing, it's a complicated world, and so we understand that, and so we want to make sure that we're doing this in a way that's going to work.
Mm-hmm. So, Kelly, if I could ask you next, how do counties think about this? Should it be at the state level or the county level?
So, I think there are a lot of challenges with the county option that make it, frankly, not a viable path to get us to the full expansion, the optional expansion in January 2014. So, the way the governor's presented the proposal, every county would have to have a low-income health program or have a neighboring county who expanded their low-income health program to cover those folks in the county next door. So we have 5 counties that never did low-income health programs because they didn't have the infrastructure. They didn't have the resources. They just couldn't figure out how to make it workable within the context of their local healthcare marketplace and their existing sort of set of services. We have another 9 low-income health programs covering 43 counties that don't go up to 138% of poverty. They go to something lower than that. And so they would have to, in addition to sort of having 5 have to build from scratch, we'd have 43 counties where they would have to double, triple. One county told me it would be 10 times the size of their existing program to go from where their LIP is today to what they think the population that would be eligible for Medi Cal would be in 2014. So operationally speaking, that is a ton of work for folks to build on something that was built to be temporary. They were built to end in December 2013. And I think none of our folks imagined in December that the low-income health programs would actually be something that was being discussed as a sort of a viable way to do a Medi Cal expansion statewide. And certainly there's a lot of open questions about how the federal government would react to such a proposal and how quickly they would provide approval. And sort of it's one more layer in the process that seems to slow us down to getting to 2014. So I think, it seems operationally very, very challenging for our folks to do it, frankly. So, and I think, and all the planning that's been going on locally prior to January, everything was being thought of as building on the existing Medi Cal program, sort of not something new and different. So, our association hasn't taken a formal position and said no to anything, but we've had a ton of counties publicly say no to the county option. So, So anyway, it's very challenging.
Anthony, do you have thoughts about what's best?
I'll be less kind than Kelly. The county-based option is nuts. Just nuts. So let me say that the context is, the low-income health programs that the counties have done are great things. We are big supporters of the low-income health programs. We figured out a better way to do the safety net that provides not just emergency and episodic care, but primary and preventative care, giving people a medical home. We've supported counties and urged counties to take advantage of that option. We're glad that we got to 53 counties just a week and a half ago, with Tulare coming on as county number 53. So I don't mean there's a lot that we can learn from what we've done with the low-income health programs, getting 500,000 people in coverage early prior to 2014, but they are not the vehicle by which to do the Medicaid expansion. Every single one of those 53 counties, even excluding the 5 that didn't do it, would have to scale up in such a huge way on eligibility and enrollment, on network adequacy, on claims processing. They've never done claims processing. It just is it's not just unwise, it's unworkable. And so, and I appreciate, I also don't presume to speak about the governor's decision-making process, but we presume that it was put in there as a way to start a negotiation between the state and the county about this issue of the responsibility of the remaining uninsured, and to deal with the risking, and the governor's way of saying we would like the counties to take responsibility for the risk and cost of the expansion. And we have some options to do it, whether it's the state-based expansion, but then combined with some sort of realignment, or a county-based option. But I do fear that now that we are mid-March, that the fact that we haven't moved on from the state versus county debate has delayed very important work of getting this work done. By not moving on from a clearly unviable proposal at the county level means that we are stalling work, whether it is to shift those 500,000 people in low-income health programs into Medi Cal on January 1 and all the planning that's going to take to do that, or whether it is having the more, I think, direct conversation between, again, what are these ongoing responsibilities. The fact that we haven't moved from the conversation that started in January, when we're now at mid-March and we have to get this stuff done in order to be ready in time, is, I think, a huge problem. It's one of the issues why we're very concerned about urgency in moving this conversation forward. But I do think that we do need a statewide option. I do think that there's a role for having that conversation about state-county costs and risks and remaining uninsured. But we can't let this debate delay and derail this historic opportunity that we have.
So, and just real quickly, Mary or Kelly, when might we know about this issue, and what's the process? How is this being decided?
Well, I think from our perspective, and totally appreciate Anthony's perspective, I think part of the challenge that we've felt is that the conversation over the last couple of months, from at least our viewpoint, has been no to both options. No to a statewide option with county money, and no to a county-based option. And we're not saying we have a preference over one or the other. And I think, Kelly and I were in a meeting today about how if we're talking about option one, how would it work? What are the questions that we need to answer? And so I think we are ready and already working on, if we want to have the conversation about, we prefer option one, here's how we think it would work, we're ready and willing and already sitting down and having that conversation. I think the challenge has been, at least initially, the sense that it was do a state-run option and address the county-state issues later, which was not one of the two options that the governor put on the table.
And I think from our perspective, the toughest part about the statewide option is the fiscal piece. The governor is asking that we use the money we're spending on healthcare now, or a portion of it. We don't actually know how much, on some new set of other programs in the human services area. So in the January budget document, it says childcare, but I think any of the human services programs that are still funded by the general fund are on the table. So it's because of the way it just adds to the complexity to the conversation. So because of the way the take-up rate may look, so how quickly people get insurance, we could have large numbers of people remaining uninsured in the early years and that declining over time. The modeling from UCLA and UC Berkeley is based on 5-year projections. And so how do we take on a new set of responsibilities today when we still are going to have the existing set of responsibilities within the healthcare system? And so it's a very challenging thing for us to sort of try to figure out. And there are a lot of risks around being responsible for new programs. And so I think that is the challenging part for us, is to try to figure out that piece. I think there may be, I I realize the governor has his two proposals as he has framed them and perhaps does not want to deviate from them. From our perspective, there may be ways to address some of the fiscal concerns and the cost sharing that don't look exactly like what was proposed in January, that still gives the administration some savings, but that also recognizes that we are going to continue to be the place where people go to get public health services, and we will continue to provide care for uninsured Californians.
And I think I would say that I understand that there's been resistance to the two options, but I think the resistance to the county-based option has been sort of nearly unanimous. And I think complete in just again even the feasibility and workability issues, and so that we shouldn't. So that if the discussion is about different ways to do a state-based option, then let's move ahead with that, and let's not let us get delayed by this conversation by having the fiction of a county-based option that really is not going to be an option. I do think that there are different ways to do it, and I think there are different ways to address the issue of how do the state and counties deal with the risk and cost of the expansion, which I will point out are relatively minimal in the context of the expansion. The state costs with regard, all the estimates are that the state costs of doing this expansion, even in the out years, is 10-15%. The federal government is picking up the lion's share of this expansion, and in fact, that's a thing to remember, is that the federal government is funding this 100% to 90% for the newly insured, and they are actually, and so they appropriately, in the Affordable Care Act, are seeking savings from the safety net themselves. There's $10 billion of planned cuts to disproportionate share hospitals, safety net hospitals, in the Affordable Care Act that goes to help fund the Medicaid expansion federally. And so when we're talking about the state taking money from the dollars that go to fund the safety net, recognize that's also happening on top of what the federal government is already scheduled and baked into the federal law. So, again, if we want to make sure there's a safety net that survives and thrives, we need to take that into account as well. But I do think that there is a way to move forward in the state-based option, and in particular to say, and to do different things. I'm not sure that the realignment proposal is the best way, and given the human services, there's different resistance to like child care than there is to other proposals. And I also think that there's problems with the realignment concept because, again, counties do wildly different things in terms of their commitment to the remaining uninsured. What LA does is very different than what Sacramento does. Really. But if you're going to realign child care or some other program, you're treating LA and Sacramento exactly the same, even though they do wildly different things. And so I do think that we hope that the state would be appreciative that there are other alternatives besides, just the two options that are laid out.
So I want to pick up with you and what the safety net should look like, and one of the things that all of you brought up in the first question, and that is, as we talked about, there will be 3 or 4 million uninsured. Two questions. How do we insure as many as possible, and then what do we do with those who remain? And why don't we start with you, Anthony?
So I do think that, again, we have this huge opportunity, and so how do we engage the work of trying to get as many people enrolled as possible? We have some very exciting opportunities with the exchange, what they're able to be federally funded to do a lot of their marketing and outreach and set up enrollment and systems. We have the opportunity to do some of that at the state level, but we would need to make some investments to do that in assisters and outreach. Number two is we can simplify the way to get to the program, and one of the things that I know that we think that the bills that are currently pending in the legislature, ABX11 and SBX1, do a very good job of really sort of taking advantage of the opportunities to really streamline the program to make it easier for people to get on the program. I know the administration has 63 pages of amendments to that bill, and some of those I seek to retain some of the administrative barriers that there are to get enrolled. and we think there's an opportunity to get as many people covered, A, so people can meet the mandate, B, so people can get the care and coverage they need, but 3, so that we can actually draw down the funds. Every person that we enroll is the money that means money we can draw down from the federal government. Every person we don't enroll on January 1, 2014 and beyond is money that we leave in Washington, D.C. and can't draw down. So, there's not just a healthcare or moral imperative. I think there's a financial imperative to try to maximize that, to really maximize the ability to get as many people in the system as possible, and then that could also deal with this issue of the remaining uninsured, because the CBO estimates are between that we could reduce the uninsured by half to 2/3, and I think we could even do more if we are innovative and about using our existing infrastructure, our current human services, our current other ways to identify people and get them enrolled as automatically and seamlessly as possible.
Mm-hmm. So, Mary, how about you next? How do we maximize the number of people who are covered, and then how do we take care of those who remain?
Well, I think one of the challenges, and I think sometimes we don't talk about this piece enough, is when we talk about the remaining uninsured, which definitely there will be people who remain uninsured regardless of what we do, even if we were the broadest, most expansive. Right. But it's, why are those people uninsured? Because I think one of the things that, at least in our conversations with the county folks, is to the extent people are going to need services and they come in for services, there's a multitude of ways they can get coverage. We're going to have, obviously, with the Medicaid expansion itself, as we've discussed, there will also be then sort of a corresponding expansion of limited scope services for emergency services inpatient for those who won't otherwise be eligible because of their documentation status. And then, there will be new changes on presumptive eligibility and other things that will, when someone is coming in to seek services, will likely end up having some sort of coverage, ability to get some sort of coverage for at least emergency services. And so I think part of the conversation we're having about the role, what's needed to be left for the safety net, the remaining uninsured, has to recognize that while there might be a lot of people uninsured, how much care are they going to actually be accessing? We want people to access the appropriate care and primary care, and that's getting people enrolled in the most comprehensive coverage possible. But I think as part of this conversation about having a viable safety net, you have to look not only at what's the number of uninsured people, but what services are they using? Because I think otherwise, if we had all the money in the world, we would be funding everything and not having this conversation about, do we need to talk about a realignment of funding from the counties. But we know that we have a Medi Cal program that is significantly large now, a significantly large part of our budget, and we have to make sure that that's sustainable moving forward. And so how do we make sure we're directing the money to the places that are the most needed? And that's a difficult conversation, because I think if we all had more money, we would want to be spending more money in healthcare than we are today.
So how do we tell how much care people are going to access who are not insured?
It's not an easy question, and I think just in the conversations we were having today, there are a lot of assumptions that are going to have to be made, but we've had to do that as we've developed the program going along, and we'll have differences in opinion about what the right assumptions are. I think our experience, as we look historically at the Medi Cal program, we've always underestimated the number of people coming into coverage and how much it's going to cost, and that is the concern that we have, the administration has, about undercounting what the exposure is, and why we want to have the conversation now. But I think we can look at history and look at what has happened and where people are accessing services today. We do have a fairly substantial amount of information from our low-income health programs, from our public hospital counties, from CMSP on what is happening today, and trying to utilize that information to help us project. And I think we'll all acknowledge whatever number we put on the piece of paper, we know that's not going to be the right number, but how do we have a range of reasonable estimates and assumptions that we can agree on so that we can move forward? And if things need to be modified as we go on, I think that's something that we could talk about.
So, Kelly, obviously this is a big issue for counties.
Sure.
Go ahead.
So on the sort of question about the remaining uninsured, so the way that historically county indigent programs have operated is you are eligible for care when you are sick. So we're not serving healthy people, or historically, the low-income health programs are different because it's really been about a medical home and getting people to get primary care and prevention services. But for the 5 counties that didn't do low-income health programs, they are still providing episodic care to really sick, really poor Californians. And so, the types of services that we would, if you assume that we continue with that model, that the statutory requirements that that counties continue to provide that type of care post 2014, means that we're going to see pretty sick people who either didn't purchase insurance because it wasn't affordable, or because they're in one of the groups that wasn't eligible in the first place for the Medi Cal expansion or for the exchange. And so I think that's sort of a tough question to answer. And to the extent that they're going to have potentially, if the remaining uninsured have sort of limited options about where they can go to get services, do they actually delay their care until they are actually sicker? And so does that create sort of a different set of costs too? And I think from sort of a smaller county perspective, a sort of a middle-sized county that's not, the rural counties pool their resources to provide indigent care, and then you have big counties that own and operate hospitals. But if their patient volume declines, but they still need to access services from specialists and hospitals and primary care providers, does that actually put cost pressure on the remaining pool of people we're trying to provide services for? Because we don't offer enough volume for folks to want to contract with us. And so does that actually drive even though we're seeing a smaller group of people, does that actually drive up our costs? On the question about sort of what we should be doing in enrollment, I would say fund it. One of the promises in the governor's budget is that they don't actually fund any new functions associated with doing the enrollment and eligibility work within counties for Medi-Cal recipients, because they don't know sort of what's going to happen with the changes that are associated with the mandatory part of the Medicaid changes. But to the extent that we do end up seeing a lot more people coming through and we're sort of not funded to do more, that's going to impact how quickly people are actually able to get services. So I think sort of that's a big, that for us, that's certainly a big component. And I think Anthony mentioned it. I think the counties are thinking pretty innovatively about how many low-income people we touch in a day in a county government, and are there ways we can be we can create access points for folks to enroll in Medi Cal. The exchange is going to be different, but I think we're trying to think as creatively as possible. And there has been some funding made available through some of the good work of the foundations that's available to all sorts of groups, but I think counties are looking at too to figure out how we can do a better job sort of outreaching and enrolling folks. Because we realize how important it's going to be. And frankly, if we lose a bunch of our funding to actually provide safety net services, we're going to have a big incentive to make sure people enroll in Medi Cal in the exchange.
If I could just follow up on one thing, because I wanted to answer your second question about the remaining uninsured, just in terms of who they are, let's just be clear about it, because I think there's always some assumptions. Right, a lot of people understand that it includes the undocumented. The undocumented are about 20% of our uninsured population right now. Because it will be a smaller number of uninsured, it's likely to go up to about a third. So about 33% are undocumented, who are currently expressly excluded from subsidized coverage in the Affordable Care Act. Unfortunately, problematically, but that's what it is. We hope that immigration reform helps some of those folks get on a path to citizenship, where they would be much more likely to be covered through a variety of mechanisms. But that looks like those paths to citizenship look like they will be pretty long paths if you read the papers correct. So we will still have that obligation and responsibility. Number two is people will find that there will still be groups of people who will find coverage unaffordable. The Affordable Care Act provides a hope that if you can get coverage, we will subsidize you so you don't have to pay more than a certain percentage of your income, but there will be groups of people who will still have to pay more than 8 or 9 or 10% of their income for coverage. And if that happens, then they will actually be exempt from the mandate. And so there will be about a quarter of the remaining uninsured will be people in that group. And then there will be people who just through life changes will become uninsured and then don't sign up in the open enrollment period, and they won't have access to coverage until the next open enrollment coverage at the end of the year, and so they'll be in those gaps. So it really let's recognize that there will be holes in the net. It will be a lot tighter and a lot better than the way it is now. But there will be cracks that any of us, could potentially fall through at some moment. So then, in terms of how to deal with them, we think that there's actually an opportunity. The low-income health programs are not a good vehicle for doing the Medicaid expansion, but they actually have taught us how to do the safety net better. And so let's redirect them on January 1, 2014, toward dealing with the remaining uninsured. Let's get folks primary and preventative care in medical homes rather than just doing episodic emergency care. If we have a limited set of funds, let's use them in the most efficient and effective way possible. Let's learn from the experience. Let's not let the capacity that has been built up over the last several years disappear on January 1, 2014. Let's use it for that purpose. And I think it also would give the state a metric by measuring the demand for existing services and measuring the opportunity for savings in the future. Because if in a certain county there is a reduced demand for uninsured services, or frankly in some counties a lack of a commitment to outreach to them, then there is an opportunity for the state to claim savings. But it's a proposal that we're looking at and that we're going to soon put out a concept paper on. But I do think that there are other alternatives than just option A and option B, that recognize what the counties do and what their ongoing responsibilities are, but provide the opportunity in the future for savings. But we can't lose capacity at this moment of transition. We're going to have a lot of people. We're going to need every hospital bed. We're going to need every healthcare professional in 2014, 2015, to deal with the expansion of coverage. And so we want to maintain that capacity moving forward.
You were getting into the last question I had before I open it up for questions, but that is just to talk about this savings. If this is a state-managed program expansion, and there are people who are covered by counties now that are shifted to the state, and there's a savings there. I'll start with you, Kelly. What's the best use of that money, and how do we figure out how much money that is?
So, I think our folks are really interested in discussing some reinvestments that could be made in the areas of public health, behavioral health, and within county hospitals that would expand provider capacity, that would invest in prevention, and some of the investments in prevention will actually help in reducing healthcare costs overall, which might actually help with some of the rate issues that the administration is worried about. I think our rural counties have made some pretty strong arguments about the lack of investment in sort of rural California, particularly in healthcare infrastructure. And even if you dedicated some portion of savings to just trying to expand provider capacity, primary care, behavioral health, what a difference that would make in those systems over the long term. And so I think there's a lot of thinking about, are there things that we could be doing locally that would actually help increase the pool of providers, which again might also help with rates if you didn't have such a scarcity of providers. And on the behavioral health side, I think there's a lot of really interesting questions about the intersection between primary care and behavioral health. And when I say behavioral health, I'm talking about mental health and substance use disorder treatment that has sort of ripple implications sort of across multiple systems. But certainly, where there potentially are quite a few cost drivers within the healthcare system are folks with multiple chronic conditions and mental health or substance use disorder needs. And so to the extent that you could build provider capacity and start spreading some of the innovative things that may be going on locally now, that might be that might transform the healthcare system across the state and provide sort of better outcomes and be a very efficient way to use the sort of set of resources that we have. And I think you potentially might actually see reductions in recidivism, both at the state prison level and sort of certainly within in and out of county jails. And so you would see sort of multiple benefits, I think, across sort of how we spend public dollars. And certainly on the sort of county hospital side of things, I think the hard part, they're sort of the most complicated part of the county world and trying to think through what is this going to look like post 2014. So right now the county hospitals get reimbursed based on their costs, we don't know what the rates are going to look like with the Medi-Cal expansion. And so the cost-based reimbursement versus a capitated rate through Medi-Cal might actually be about the same. So you might not actually see a ton, you wouldn't see any savings that's sort of under sort of worst case scenarios about rates. And so that question of savings becomes really hard when you're looking at systems and where patients are going and whether or not they have a payment attached to them, as well as this question about rates. And then you have what Anthony mentioned earlier about federal funds declining. And so how do you just sort of delicately figure these things out so that you're not taking resources away prematurely from our existing healthcare infrastructure and sort of destabilizing systems? So, this is why this conversation is hard. So, I mean, and I think we recognize that the state has needs. And this conversation about counties sharing in state costs is probably unavoidable in some respects. But that doesn't mean that there aren't things that we could be doing that would help inform the state's concerns about affordability and sustainability, which would benefit sort of both parties.
Mary, why don't it go to you next? How do we figure out how much of a savings there might be, and what's the best use of that money?
Well, if I could answer that in a short sentence, I'm sure we'd all be better off. I mean, I think it is about sitting down and going through. I mean, we were creating lists today of there are 10, 15 moving pieces that impact this conversation, and I think we've never said it would be easy to figure out what the interactions are, and we just want to sit down and figure that out. I think from our perspective, given, as Anthony's talked about, there is a lot of federal money on the table. So there is a way for us to look at the opportunity of maximizing federal funds through a variety of opportunities that we can think through in terms of rates or other things that can help with this conversation about generating savings at the county level. From our perspective, as you know, if there are savings, which we believe there will be, we are viewing that as a reinvestment in our entire Medi-Cal program. We know that there are going to be increased costs in our existing Medi-Cal program starting next year and growing over time. And again, as I mentioned at the beginning, once we have additional 1 million, 2 million people in our program, there is more cost pressure, as Kelly mentioned, on our rates and ensuring that we have adequate provider networks. And so we're viewing this conversation as about investing in our entire Medi-Cal program. There's funding that's being spent today, state funding going to counties for healthcare services. And we're not saying take that and spend it on roads. We're saying we have this issue of our Medi-Cal program.
We're not saying spend it on roads.
No, I know. No, I didn't mean that. But what we're saying is invested in the health. I think we're talking about different investments in the healthcare system, and we're viewing it as an investment in the Medi-Cal program overall.
Mm-hmm. And Anthony, I take it you were suggesting that we might continue LIPS with this money, or
So I mean, a couple of things. One is, I mean, again, the question is, are there savings is actually a good one. If you have 3 to 4 million, 3 to 4 million people, and again, let's say you even take the most lowest assumption of what Medi-Cal costs per patient per month, kind of the extrapolation. You're in a realm of $5 to $7 billion, and I say that number knowing that it's probably wildly inaccurate, but I'm trying to give you a sense of scale, right? Which is that it is multiple times what the state and counties combined currently spend on the safety net. I mean, which is the estimate is that the state spends something in the state realignment funds to counties on this issue is around $1.4 billion, and then overall spending is somewhere between $3 to $4 billion. If we were to give even the lowest cost Medicaid, given how notorious cheap Medi-Cal is, you're still in a sort of magnitude universe bigger. And so the question is then, how do you use those resources most effectively? I do think there is an opportunity for savings in a longer time period, but I do think it will take time. It will take time for us to enroll as many people as possible. It will take time to sort of deal with a lot of the pent-up demand issues of the first couple of years of implementation of health reform. But I do think that, and so our notion is use the low-income health program as a way to support the low-income health programs as a way to get people a coverage-like product. It's not full Medi-Cal, but it is better than sort of a basic safety net. It could, and it also can be a metric by which counties determine what is the demand in their county and also what is their commitment, because we know some counties do cover the undocumented, some don't. Some have broad eligibility rules about what they serve, some don't. And so to measure that, so that if a county is not meeting meeting their commitment, then there is more of a more savings taken. We would want those resources to go into safety net and other means, help fund providers who do fund the remaining uninsured in those areas, support provider rates. I will also mention that, I would be remiss if I didn't mention that we have an opportunity to improve benefits as well. We made significant cuts to Medi Cal benefits in 2009, eliminating dental and nearly 10 other benefits. If we restore that in the Medi Cal program, it would be a relatively small cost, but it actually would also mean not only would we get the one-to-one match for all the existing eligible, but it would be 100% paid for the newly eligible. And so, again, that's an opportunity where we're going to get more than a 50-50 match to do it. And so, if we need to raise revenues to take advantage of that opportunity, then let's talk about raising revenues. But there are opportunities that we have in front of us that we need to take advantage of, that the Affordable Care Act is providing us for the first time, and we have an opportunity to make Medi-Cal, not just expand Medi-Cal, but improve upon it.
Thank you. So I want to open it up to questions and get into some of these issues. One here.